Managing a severe autoimmune disease during pregnancy presents a profound biological conflict. The medical interventions required to keep the mother alive are often the exact substances that threaten the developing fetus. As the crystalline structure cracks, if a maternal immune system awakens from remission, the resulting inflammatory cascade immediately endangers both patients. Consider a 27-year-old female with systemic lupus erythematosus. She has been in remission for 12 months following a life-threatening flare, maintained on 75 milligrams of azathioprine and 5 milligrams of prednisone. Now she wants to become pregnant. The immediate intuitive response from many patients, and even some clinicians, is to immediately halt these immunosuppressant drugs to protect the baby from toxic exposure. Abruptly discontinuing maintenance medications like prednisone or azathioprine before conception is the absolute least appropriate clinical action you can take. This clinical panel outlines the 6 months quiescence rule. It explicitly warns that stopping prednisone prior to conception triggers a high probability of a severe disease flare. The autoimmune disease must remain completely dormant on maintenance therapy for at least 6 full months prior to conception. A severe maternal lupus flare statistically carries a far higher risk of fetal loss, premature delivery, and maternal mortality than the controlled use of targeted immunosuppressive therapy. Successfully managing an SLE pregnancy is a dual patient paradox. Strictly maintaining maternal immunosuppression is the biological prerequisite for fetal survival. If the mother must stay on daily steroids to suppress her lupus, the obvious question is how the developing baby avoids massive glucocorticoid exposure. The answer lies in the placenta. It operates as a highly specialized active biological filter between the maternal and fetal bloodstreams. Specialized syncytiotrophoblasts cells within the placenta act as targeted molecular gatekeepers, intercepting and neutralizing specific maternal medications upon impact. This mechanism graphic details the specific enzyme driving this defense, 11-beta-hydroxysteroid dehydrogenase type 2. It rapidly converts active maternal prednisone into completely inactive cortisone. Over 90% is neutralized before crossing into fetal circulation. Because of this enzymatic shield, maintaining the mother on low-dose prednisone, under 10 milligrams a day, effectively suppresses her disease flares without exposing the fetus to harmful steroid levels. While this biological filtration elegantly solves the problem for prednisone, it forces a rigorous evaluation of all other lupus medications that lack this natural shield. The placenta cannot filter every chemical. Establishing a strict pharmacotherapy matrix is required long before conception. Looking at this safety reference table, hydroxychloroquine is a mandatory anchor, having maternal flares. Azathioprine is also safe. Though it crosses the placenta, the fetal liver lacks the activation enzyme. Conversely, other immunosuppressants bypass fetal defenses, functioning as lethal teratogens that cause severe malformations. Drugs like mycophenolate mofetil, the teratogen methotrexate, and systemic cyclophosphamide fall into this high-hazard category. They must be strictly discontinued weeks to months before the patient even attempts to conceive. Entering a lupus pregnancy safely requires successfully swapping these teratogens for placenta-safe guardians, preserving the 6-month remission window without poisoning the fetus. Even with a perfectly calibrated medication regimen, the fetus remains vulnerable to invisible serological attacks, particularly as the pregnancy enters the 2nd trimester. This profile highlights antiphospholipid antibodies, which induce placental thrombosis, risking preeclampsia and miscarriage. Counter this with low-dose aspirin by week 12. Secondly, anti-Rho and anti-LAW antibodies cross the placenta, attacking the fetal AV node. This requires strict serial fetal echocardiography to identify early heart block. Deploying this targeted serological radar neutralizes specific maternal threats, allowing the fetus to safely navigate the highly vulnerable 2nd trimester window. Finally, the timeline moves to the immediate postpartum period. Delivering a healthy baby does not mean the danger has passed. Upon delivery, placental steroids rapidly plummet, while maternal prolactin simultaneously spikes to initiate lactation. This disease trajectory chart illustrates the postpartum trap. The high prolactin surge heavily stimulates autoreactive B cells. If maintenance drugs were stopped earlier, this physiological collision triggers a severe, often life-threatening maternal flare. Surviving the pregnancy itself is hollow if the mother crashes during the postpartum period. This reality validates the absolute necessity of maintaining safe immunosuppression from day one. These high-yield summary pearls distill the entire protocol. Never stop safe maintenance drugs like azathioprine or low-dose prednisone pre-conception. Hydroxychloroquine is mandatory throughout, and aggressively monitor high-risk antibodies. Mastering these exact autoimmune and reproductive pathways delivers perfect board exam accuracy, and in the clinic, it protects 2 lives simultaneously.